the doctor missed, that means the doctor missed 80% of thyroid nodule by physical exam. Moreover, even when they look to the thyroid nodule that are large enough, which is 2 centimeters, still the physicians, expert physicians, were able only to detect half of the thyroid nodules and miss the other half. Just tells you we were not designed in a way to be able to detect thyroid nodules by physical exam. Surprisingly as well, many of these nodules detected by expert physicians, they were found not to be a true nodules, meaning they brought some patient, they told them, I think you have a thyroid nodule. Then they sent them for ultrasound, and the ultrasound showed no nodules in 68% of the time. So the end result is we are not good in detecting thyroid nodule. Our fingertips are not sensitive or specific in picking up the thyroid nodules. That leads us to the next ethical dilemma, which is, shall we order ultrasound for patient to screen or find these thyroid nodules or not? And this argument has 2 parts, order ultrasound or not. We may argue that ultrasound should be done for most of our patients, given what I mentioned in the previous slide, that physical exam is a poor tool in detecting a thyroid mass. We may argue that as a physician, our main target is to protect patients' life, and we don't want to miss a cancer. If I don't do an ultrasound, I may miss a thyroid cancer. This is physician anxiety. You may argue as well that, oh, I found a thyroid mass. This mass turned out to be a cancer. I saved this patient's life. So what I did was appropriate. Some patients, as we know, are very anxious as well, and they want you to do ultrasound for their neck. And on top of that, there's a cultural pressure where patient will come to you and ask you to do everything. And sometimes because for non-specific complaint, such they read the weight gain is due to thyroid, let's do for me a thyroid ultrasound and a blood test. This is the argument in favor of the ultrasound. And the other side, if we look to the argument not to do ultrasound routinely for all your patients, we can argue that most thyroid nodules are benign. As we mentioned, 95% chance these nodules are benign. When you do an ultrasound and you find a nodules, a lot of time you induce patient anxiety. What you were trying to avoid is triggered, because now patient have a thyroid mass that may need a follow-up by ultrasound in 6 months, 1 year. You may need to do a biopsy, and you triggered a great deal of anxiety for patient and long-term follow-up. And that was, I told my patient usually, I told them, we really don't need to do ultrasound unless there's a need. We don't need to know what's inside the thyroid gland. If we find a thyroid nodule, you're stuck with me and I'm stuck with you. We need to monitor them for several years. Now, the last point, and this is really the main aspect of my presentation, is I will try to convince you, that's my goal. I'm gonna try to convince you that ordering ultrasound for most patients will not save their lives, unlike what we think. And in order to convince you, I'm gonna present for you 3 observational studies to show you how this is, what I'm telling you is true. We'll start by this slide. This slide reflects the incidence of thyroid cancer over the last 18 to 20 years in the United States. If you look here to the green curve, it represents the incidence of the thyroid cancer. And as you can see, as 1998 and later, we have a surge of thyroid cancer screened and found thanks to the overutilization of ultrasound. The ultrasound machine became available in many physicians' office, and physician ordered many of these ultrasound. Nevertheless, if you look at the death rates from that, it did not change. So we ended with many thyroid nodules I'm sorry, that required, many of them, they went through unnecessarily fine needle aspiration biopsy. Many of them received radioactive iodine and surgery, and they got complication from the surgery, but we did not change the death rate. So people who received care in 1992 for thyroid cancer, they had a similar death rate like people from 2019. This indicates that overutilization of ultrasound resulted in many unnecessarily finding of small thyroid cancer that did not translate in better mortality rate. Okay, this is the second observational study. And if you see here under detection, this is the incidence of thyroid cancer from thyroid nodule found in the United States based on gender. And you can see women have a 3 times chance to be diagnosed with a thyroid cancer, find a thyroid cancer compared to men. The reason for that is probably multifactorial. Mainly the women are more health conscious. The women are more likely to follow physician recommendations and do ultrasound or a biopsy. And thirdly, the women have a thinner neck and less muscle in the neck, make it easier to detect thyroid nodule by ultrasound. I'm sorry, by physical exam. But look to the right side of the slide. Despite 3 times more detection of thyroid cancer and less in men, the risk of death is the same. So women are going through multiple unnecessarily imaging study, biopsies, radioactive iodine, surgery, and this is not translated in better survival rate. And that's what is mentioned here. All right, I'm gonna move to the third observational findings and to convince you that ultrasound routinely is not helpful to save patient lives. Now we are in the United States, a rich nation, and I'm gonna take you on a journey to South Korea. South Korea is another very rich nation, advanced in the science of thyroid nodules. It has a population of 51 million people. They decided to implement ultrasound thyroid as screening test for their nation to screen patients for thyroid cancer. They ended with 15-fold increase in the thyroid cancer detection. And no wonder they granted and awarded the world's highest rate of thyroid cancer across the globe. Over this time, the incidence of cancer shooted up more than 15 times, 10 to 15 times, if you see this blue curve. They went from probably 4 in 100,000 to 60. But look at their mortality rate, it did not change. So despite all this effort, screening unnecessarily people, the cancer rate did not change. And the reason for that is just, again, the thyroid cancer are unique. There are many of them. They are very indolent. We live with them, we die with them. They're not always causing harm for us as a human. So I hope by now I convince you that ordering more ultrasound for your patient with no symptoms is not gonna save lives. If any, it may gonna harm them, and that's the next step I will try to convince you. So you're not just, when you're doing an ultrasound for a patient who did not require ultrasound of the neck, you actually may cause harm, not only not benefiting the patient. Okay, look here. We received the major update, and this is the one I wanna to come up with at the end of this first few slides. It's from United States Preventive Service Task Force. It's a committee responsible to determine which preventive medicine measurement need to be done. And in terms of screening patient with thyroid ultrasound, their evaluation for that was grade D. If you look to see, which is, they say recommend against screening for thyroid cancer in asymptomatic adults. If you look what D means, they will clearly say there is a moderate to high certainty that a thyroid ultrasound has no net benefit, and probably, and here where I wanna focus, harms outweigh the benefits. So ordering ultrasound for a patient who doesn't require ultrasound, it will cause more harm for your patient than benefit. I'm going to give you examples how ordering ultrasound may cause harm, not only no benefit, harm for patient. This is something we, as endocrinologists, we see almost every week, a case like that. And we know that patient did not require this ultrasound. This is an example. A lady came, had an ultrasound. The ultrasound found a nodule, a biopsy done, and the biopsy came non-diagnostic. The patient came, for example, to Dr. Fateh or Dr. Sam. Okay, the doctor appropriately ordered another biopsy, and the other biopsy again came back non-diagnostic. It's not uncommon. It happened in 5 to 10% of patients. Now, the Dr. Sam or Dr. Muhammad decided to do a core biopsy, trying to save the patient from going through unnecessarily surgery. But the biopsy came again, third time non-diagnostic. And this time he used more invasive procedure. It's called a core FNA biopsy. At this stage, Dr. Sam decides to send the patient for a surgery. The patient was found by the surgeon. The surgeon decided there's multiple thyroid nodules on both sides. He appropriately advised the patient to do a total thyroidectomy, since some of these nodules were, for example, 2 centimeters. The patient had a total thyroidectomy, but unfortunately, this led to, which happened in 2% of population, even with the best hand, the patient developed hypoparathyroidism, as the condition happened when the parathyroid gland are removed by accident or damaged during surgery. This could happen with the best hand, where the incidence is 1 to 2%. The patient now become calcium dependent. It needs calcium pills to survive, and she will need lifelong monitoring. These patients, they will require a large dose of calcium. We're not talking about 1 or 2 pills a day. They will require anywhere from 2 to 12 pills. These are large pills. They are hated by the patient. They don't like them. The patient will keep coming and they will ask me how often I need to see you. And I usually try to joke with them and tell them this is a lifelong commitment between the patient and me. And you're gonna stop seeing an endocrinologist either when I die or you die. This is like, it's a lifelong treatment. And I try to let them cope with the idea they will need calcium lifelong. The study showed this, a lot of these patients will develop depression, decreased life quality. They will end in the ER multiple times because they have severe numbness, tingling, muscle spasm. Some of them, actually, they quit taking medications, though few, and they may have a seizure and cardiac arrest. I had in my life only one case like that, where patients died from hypoparathyroidism. Now, it's all started with a physician clicked on ultrasound, which lead to all these complications. What I mentioned in the bottom is not a myth. There are multiple studies done in Germany, which showed permanent hypoparathyroidism is associated with anxiety and depression. There's a study done in Sweden using the registry showed that this was significantly higher among patients with permanent hypoparathyroidism after total thyroidectomy. Another study as well done in Turkey and showed similar findings. Now, you may argue this is a rare incidence. It happens only in 2%, but I'm going to give you a few more examples how FNA and ultrasound may be harmful for the patient. Here we have another patient. We did a thyroid ultrasound. We did a biopsy, and the biopsy came back benign. Now, you may argue this is a good thing, or we may argue this is a good thing. And the contra argument is that we should not have done the ultrasound, since this mass to start with is benign. We should not have went through the biopsy. We should not have done the ultrasound. This ultrasound did not save lives. And this ultrasound just resulted in extra biopsy and anxiety for the patient. Bear in your mind, these patients will require several years follow-up with repeat ultrasound to make sure these nodules are not growing in size, or if the biopsy is falsely negative, to repeat the biopsy in 1 or 2 years. I'm going to go to a third example. Now, this patient has a ultrasound, thyroid biopsy was done, and now we have a cancer. And now here, yeah, we might be saving lives, But again, based on the observation and study I showed you in the past, this is not necessarily translated in actual life-saving process, especially for small thyroid nodules, half centimeter, 1 centimeter. It depends on the patient age. If the patient age is 70 or 80, you're probably not saving his life by doing this biopsy. You just induce anxiety. You just let the patient undergo through biopsy, surgery, and radioactive iodine therapy. But definitely some of these treatments are appropriate. I'm just showing you, we at 2022, we still try to determine which patient will benefit from the biopsy or not. However, when there are multiple, when you encounter many thyroid nodules, you have to make a decision which one to biopsy or not. So I'm going to give you a few examples and show you that what shall we do. So if you have a patient with hypothyroidism, my recommendation, don't do ultrasound. There's no indication to doing ultrasound for such a patient. If you have a patient with elevated TPO, most likely he doesn't need ultrasound. Now I have put a question mark because the CMS in United States will cover such indication for ultrasound. I'm really not sure why, but it's something covered by Medicare in United States. For me, I personally don't do ultrasound for elevated TPO. I don't think it will give too much information. By doing the ultrasound, I bear in my mind that I don't want to do harm for my patient picking up unnecessarily thyroid nodules. Definitely patients who are asymptomatic, please don't do ultrasound. Patient who come with non-specific symptoms such as weight gain, fatigue, he tells you or she tells you, I need a full thing done for my thyroid, I need ultrasound. Try to convince them. That's what I tell them. Tell them, you really don't need to do ultrasound unless I feel something by physical exam. And many of them, they actually do. They don't want to do the ultrasound. Okay, and patient who want everything to be done, the thyroid, of course, no biopsy. I'm sorry, no ultrasound. Now, because of this updated recommendation we got in 2017, which recommend against screening ultrasound, we start over the period of 2014, even before the recommendation were published, due to increased awareness of overdiagnosis, to see a decline in the thyroid cancer detection rate, which was good because we know we're not saving life when we are picking up more of these thyroid nodules. However, I have to give a disclaimer here. This is not, these recommendations about screening are not for children who are exposed to radiation, such as people in Ukraine around Chernobyl area who were born before, who they were kids when Chernobyl fallout happened, Fukushima, nuclear, Nagasaki. All these patients are not including in these recommendation. Patient with a family history of thyroid cancer is very common in UAE, and family history of thyroid cancer. Now, the disclaimer by the United States Preventive Service Task state that even in this case, the benefit of early detection have yet to be demonstrated, but those people need to be screened. So you may ask when then we to order ultrasound. This is some suggestion from you based on the cms.gov webpage, and I think these are appropriate. If you feel a palpable neck mass or a thyroid mass, definitely do an ultrasound. Patients who have persistently or severe hyperthyroidism. So a patient with a TSH 0.2, 0.3, you probably can avoid ultrasound, wait for 3 months, and repeat the ultrasound in 3 months. I think this is more appropriate than doing the ultrasound from first time. Many times the thyroid hormone will reverse to normal within a first visit. If the TSH is severe, TSH is severely suppressed, indicating severe hyperthyroidism, I think it's a good idea to do ultrasound. It may help you to differentiate between a Graves' disease and thyroiditis. If there's a mass effect, such as unexplained hoarseness or dysphagia, bear in mind, most of the time, not always, but most of the time, when patient develops hoarseness from thyroid nodule, the thyroid nodule will be really big, in the size of an apple. And you can visibly see it and the patient will point it out. But again, hoarseness or dysphagia is reasonable indication for thyroid ultrasound. Some thyroid nodule will grow inward, not outward, and they will be buried under the neck and the skin, and you need ultrasound to find them. Now, I mentioned about the patient anxiety, but I have to say, if the patient has feeling a neck mass, you are obligated to do ultrasound. This is my recommendation. And I picked up few thyroid cancer when the patient said he has a neck mass or feeling a neck pain. The neck pain also a helpful indication to do an ultrasound for, because the ultrasound may find necrotizing a thyroid nodule or a subacute thyroiditis. These are picked up by the ultrasound and give you a diagnosis. All right, so the ultrasound now was ordered properly. A nodule is found. Now you got the report. So what do? This patient coming to you, chief complaint, thyroid nodule. So that will move us to the second part of the presentation, which is how to approach thyroid nodule management in 2022. We'll talk about the ultrasound scoring system and updated cytopathology scoring system. So the nodule first need to be evaluated are the nodule that you really need when you see the ultrasound report by radiologist to read it carefully. The radiologist a lot of time will give you many clues about thyroid nodule, which one looks suspicious or not, and whether you need to proceed further or just provide reassurance. So usually nodule less than 1 centimeter are not required to be biopsied in most of the cases, except if there's an abnormal cervical lymphadenopathy, not regular one. So when you have a reactive lymph nodes, is not an indication to do FNA biopsy. You need a suspicious lymphadenopathy. And most of our radiologists, they will give you a hint. This nodule look, for example, suspicious. There's microcalcification in the lymph node, or this nodule is non-reactive. That may raise awareness about thyroid nodules. But in most of the time, really, you really don't need to do a biopsy for these nodules. There's a disclaimer as well that attempt to diagnose and treat all such small thyroid cancer probably is not needed. The harm is more than the good. Now, as any patient who come with a new complaint, you need to obtain history and physical exam. The history usually is focused. You need to look for radiation exposure. We talk about Ukraine, Chernobyl incidents, and Fukushima. I diagnosed few patients with thyroid cancer from Ukraine. There's familial thyroid carcinoma. If there's a rapid nodule growth in young patient, most likely this is benign. It's most likely it's a cyst that suddenly grow in size. It's not a cancer. But if you see a rapid nodule growth in elderly patient, this will raise the concern of undifferentiated thyroid carcinoma, like patient 50, 60, 70-year-old. Patient 30 or 40, probably this is only a cyst. Remember, thyroid cancers are very, very slow growing tumors. If you see a hoarseness, a physical exam should be done, examining the neck and look for any abnormal lymph node. Thyroid lymph nodes that are large or sticky and mobile, not tender, could raise the concern of suspicious lymph nodes. About the lab study, you could tell my list is not that long. It's only one blood test, really what you need, the TSH. The TSH will help you in determining the management and risk assessment of thyroid cancer. So if this slide showed you, if your TSH less than 0.4 or less than 1, the risk of cancer is very low. Where if the TSH is above 5, your risk of thyroid cancer is almost 30%. It just has some prognostic factor, as we will see in the next few slides, but it's not a determining factor in this regard. So the other question is about calcitonin measurement. Most of the time, by the way, this is not covered by the health insurance company. Here in Health Plus, I don't see me or any of my colleagues ordering calcitonin, unless the patient has a history of medullary thyroid carcinoma, or there's a family history of medullary thyroid carcinoma, which is again very rare cancer. So it's controversial. It may trigger false positive. It needs special confirmation test if the measurement came above 10 picogram per ml. False positive when you have a renal insufficiency or patient on proton pump inhibitor. So in general, we don't use it. The most updated guidelines still did not give a definite answer with or against measuring calcitonin regularly. In the United States, they don't do it routinely for patients with thyroid nodules. TPO is not indicated. I know the insurance company will pay for them, just maybe to look for Hashimoto, but it will not help you significantly in management. I want to focus about thyroglobulin. I see a lot of time thyroglobulin ordered for a patient with thyroid nodule. It's really not necessarily. I think thyroglobulin can induce a lot of anxiety when it's high. Thyroglobulin level could be normally elevated in benign goiter, in hyperthyroidism, and in any cause of destructive thyroiditis where there's a leak of the thyroid hormone and thyroglobulin level will be elevated. Thyroglobulin level could be falsely elevated or low in patients with thyroid, concomitant thyroid, thyroglobulin antibodies. So really, there's no need to order them. Thyroglobulin is good for patients who found to have a thyroid cancer treated, and it becomes like a cancer marker to follow up after treatment, but not as a screening test for thyroid cancer, not as a test for thyroid nodule. Now, we decided we have a thyroid nodule. This nodule is 1 centimeter, more than 1 centimeter. So we looked for any suspicious finding in the ultrasound. There's no extension, extrusion, or abnormal lymph node, no family history of thyroid cancer. If it's none, there's no need to do anything for this little nodule. If they are more than one, you may argue to do another ultrasound in 1 year, but by guidelines, I don't think you need to do unless there is suspicious finding. And we'll go over that in a moment. But if the nodule is more 1 centimeter, it were to be assessed. If the TSH level or concentration is low or low normal, below 1, then you can do a thyroid scan. I need to say, and I think most of my colleagues, we don't do thyroid scan unless the nodule is quite large. So even 1 centimeter, 1.5, I usually don't do thyroid scan. I find it a very low yield, and there's too much radiation exposure for the patient. So usually, I'm sorry, let's go back here. So if the thyroid scan showed a hot nodule, then this nodule can be treated surgically by resection, by radioactive iodine, or monitoring based on the TSH level. These nodules, if they are hot, they don't need a biopsy. If you go to the other side, if the TSH concentration is normal or high, then FNA is assessment, not FNA. FNA assessment is required. Patient with a cold nodule as well from the thyroid scan will require FNA assessment. In the old days, meaning maybe 5-7 years ago, the rules was you do a biopsy for any thyroid nodule more than 1 centimeter. So I used to do many biopsies. In fact, I had one whole day in the United States just to do biopsy. I will assign, for example, Thursday for biopsies or Fridays, and I will do in a week anywhere from 8 to 16 biopsies. Of course, most of these, we know now by now, most of these biopsies are not needed. So the science or the field of thyroid nodule evolved over this time. And we had a second major update where the American College of Radiology published their paper in 2017, and they came up with a new scoring system for thyroid nodule. It's called Thyroid system. And this, the radiologist will look for the thyroid nodule composition, echogenicity, shape, margin, and foci inside the thyroid nodule and give a score for the nodule. You don't need to know about this, but you need to familiarize yourself with the scoring system. The radiologist will give you a score, TR1, 2, 3, 4, or 5. And based on that, the higher the number, the higher the risk this nodule could be a cancer. And they give you as well recommendations. So TR1 and TR2, they don't need a biopsy. And TR3, TR4, they need a biopsy if they are larger than 2.5 centimeter instead of 1 and 1.5 centimeter. Only nodules that are TR5 who are required a biopsy, they are more than 1 centimeter. That has a large implication on our practice and reduce the number of unnecessarily FNA biopsy we did. This led to a reduction in the number of unnecessary biopsy. And now we have at least 50% reduction in the number of biopsy we did. We saved many patients from going through unnecessary biopsy, going through unnecessary surgery, unnecessary radiation, unnecessary surgical complications. The false negative rate is only 2%, meaning this system will miss only 2% of nodule. However, given the fact you keep a follow-up on these patient, probably the risk on the patient is even less. All right, so we did the biopsy, the sample sent to the cytopathologist, and then FNA report was generated. In the past, there was a problem among cytopathologists. They would use different diagnostic terminology, morphologic criteria, and they don't give you a clear-cut like terminology for the risk of malignancy. This had changed over years. So we used to call the cytopathologist and ask him, do you mean this is indeterminate nodule? Do you think this is benign? It depends where they were trained and which university they graduated from. I saw that even in the United States, with the same country, every cytopathologist used different terms. But this changed over time, and in in 2017, we had our major update, which is Bethesda classification system. This was published in 2019, implemented in 2009, and revised in 2018. This system saved doctors a lot of headache. So now we have a very clear-cut system. It's a universal language like English. All the words speak the same language for thyroid nodule, at least the Western world. So now they give you a score for the nodule and a name, and this will show you the risk this nodule be cancerous. And that helps us to streamline the management of these nodules. So the FNA report will come with a score 2, 3, 4, 5, 6, or 1. If the nodule has a score of 2, it will be in Latin, but I made it in English just to make it easier. This means this nodule is benign, just monitoring. If it's 3 or 4, it's indeterminate and need a further assessment. If it's 5 or 6, this is suspicious for a cancer or cancer. These patients need to be sent to a surgeon. If it's 1, then it's non-diagnostic and a repeat FNA is recommended. Now I'm gonna show you the next slide. It's very busy. I'm not gonna go over it, but this is the algorithm from UpToDate for the management of indeterminate thyroid nodule, category 3 and 4. I just list that to show it's so complicated. It's out of the scope of this presentation. And these patients are best sent to an endocrinologist to serve them. And we will take care of them in this stage. So when do we send patients to surgery? We send them if they have Bethesda category 5 or 6, which means suspicious of cancer or cancer. If there's multiple inconclusive FNA from category 1, 3, and 4. If you have a very large thyroid nodule, more than 4 centimeters, this is optional, or patient has compressive symptoms from thyroid nodule. Thyroid nodule 1 to 2 centimeters are unlikely to cause dysphagia or dysphonia. So you need to make sure these compressive symptoms are truly from the thyroid nodule. We can send to surgery if patient has a hot nodule, if no radioactive iodine therapy is desired. Medical therapy for thyroid nodule is very limited. We barely use medication to shrink the thyroid nodules. In area with iodine sufficient region, there will be a 50% reduction in nodule size if in 25% of patients. Remember, this treatment will increase the risk of atrial fibrillation, heart disease, and reduce bone density. So in general, we really try to avoid it. I'm not aware. Most of our colleagues in Health Plus, diabetes and endocrinology, we don't use suppressive therapy, especially in Abu Dhabi. We are area with iodine sufficient region. We are a coastal city, not treating with T4. Area with iodine deficiency, mountain area where they don't have access to salt-rich, iodine salt-rich. A trial of T4 in young people is appropriate. How we follow this nodule? Usually we do a follow-up in 6 to 12 months for a nodule who have a suspicious characteristics, 1 to 2 years with the nodule with low to intermediate suspicion, and 2 to 3 years in nodule with low risk. I think by now, I hope I give you an idea about the major updates. So the most important, avoid unnecessarily thyroid ultrasound. There's a new ultrasound classification should be implemented in 2016, 2017. And the Bethesda cytopathology classification system has helped us to stream many of these thyroid nodule management. I'm going to go to the last part of the presentation, what the future is holding for us. The three things we are seeing more and more right now, the use of radiofrequency ablation instead of surgery. There are mathematical prediction module for thyroid nodule, the use of machine learning, molecular study, and PET scan use for indeterminate thyroid nodule. Now, the last two items I will skip due to time squeeze, and I think these are beyond the scope of current audience. I'll talk about radiofrequency ablation. This is very exciting, developing field. They were approved by FDA in 2018. And basically, they can replace surgery in many cases. It can reduce the biopsy by 76% with the treatment. It's basically like a thyroid nodule done by ultrasound in outpatient setting. It takes 20 to 30 minutes. And the physician will apply heat to kill the thyroid nodule. And within a period of time, the nodule will shrink in size by 76%. If there's overactivity, it will, I'm sorry, this is the right slide. Okay, so 76% reduction in the size. And if there's overactive thyroid in 2 years, 82%, they become euthyroid, achieve euthyroidism. In 2018 as well, we developed a prediction for risk thyroid malignancy in individual patient. This depends on the two facts that thyroid cancer is more common from age 30 to 70. Children are very high risk for thyroid cancer. So if you find thyroid nodule in a young boy, 16, 17-year-old, this could be a cancer. So you need to assess those patients. But as you go down the road here in the age from 30 to 70, the risk of cancer is low. The same thing for the TSH, the higher the TSH, the higher risk of cancer. So this study developed a mathematical equation where they plot the type of goiter, solitary versus multinodular, the gender of the patient, the age, and the TSH concentration to give you a prediction of thyroid cancer. And they give us an example here. So for example, the risk could be 3% in a female 40-year-old with multinodular goiter and TSH 0.5, while it could be 50% risk of cancer in a 16-year-old young male with a solitary thyroid nodule and TSH of 4. Now, this is by itself is not enough to make decision, but I think in the future, such module may be implemented with the thyroid to improve the selection criteria for which patient need a biopsy. I'm going to go to the last topic of today, which is the machine learning. This is an exciting field. As many of you probably know, the machine learning is part of artificial intelligence. It's the process of using mathematical models of data to help computer learn without direct instruction. So in a study published in 2022 and presented during the last Endocrine Society meeting, they present this data. They brought 30,000 images from 600 plus thyroid nodules, and they fed those images to a computer who went ahead and processed the data and developed a machine learning system that can answer a question, if this nodule is a cancerous or not. Afterward, they brought a list of images from a different hospital, 145 nodules, and they let the system analyze the images and give them an answer whether this are cancerous or not. They had the previous answer before, and when they did the analysis, they found the sensitivity of this machine or software is 97%, and the specificity 61%. What does that mean? It means the sensitivity of this new technology is comparable to that of fine needle aspiration biopsy. So the computer is able to give us an answer based on the images without even the need to do a biopsy, not an ultrasound, a biopsy. However, this is not specific, it's sensitive. So it means it's a good tool to rule out thyroid cancer and avoid biopsy. So, but it will, if it's come back positive, then you'll need to do a biopsy since the algorithm is not specific. This will need time more to be incorporated, and we'll see, this will be exciting to see what the future will show for us. This is the horizon and what we learned over the time, and development of different aspects helped us to better treat patients and select patients for nodule. Many of these patients are unfortunate. They have nodules that are benign. We are unable still to determine 100% which one has a thyroid cancer or not, which one will benefit from doing surgery or observation. I think the future will help us to find more answer, especially with the molecular markers, which I did not address due to short on time, and I think this is beyond the scope of current audience. This is the summary. I want to finalize. This is my last slide. Please, if anything, I want you to come out of this presentation is, I know we are all physicians. We look to the best of our patient. We are always anxious about missing a thyroid cancer. But remember, ordering ultrasound thyroid for asymptomatic patient is probably harmful. So try to avoid the urge to do ultrasound, the pressure from the patient. Try to counsel the patient about the ultrasound is a weapon with two edges. It could be good or harmful and should be used under strict criteria. One click from you can change patient life forever. Second thing, biopsy of most thyroid less than 1 centimeter or TR2 are not recommended. I see still some patient coming for me with a biopsy for TR2 thyroid nodules, or even less than 1 centimeter, unless the patient has risk factor. And finally, I encourage you to speak to your local radiologist in your hospital or center. If they are not using the thyroid system, they really recommend it to use it. It will help you, it will help your patient, it will make everybody happy. It's an easy system, any radiologist can easily learn it and use it. This is the end of my presentation. I would like to thank you all for listening. Thank you for Dr. Neha as well for nominating me to give this presentation. Thank you for Health Plus and Mubadala for the opportunity. And this is the end. Thank you so much. I'm not hearing you, Dr. Neha. I think, Dr. Neha, you are mute.
Can you else hear me, Anit, Cherry?
I hear you now.
Okay, good. Okay, so just wanted to thank you for the excellent lecture and for covering so many points and such interesting points that will help not just endocrinologists, but our family medicine colleagues, even the patients. So let me first go to the questions and then we will come back to anything else you'd like to discuss. So there is a question from Bincy. She wants to know, once we start thyroid tablet for hypothyroidism, can we stop the medicines once it has come back normal, or do we need to continue lifelong?
So the thyroid hormone replacement is given for multiple different conditions. We give thyroid hormone for patients who have hypothyroidism due to Hashimoto thyroiditis, sometimes temporarily for patients with post-viral hypothyroidism or postpartum thyroiditis, and sometimes for patients with thyroid cancer after treatment. In many cases, we are able to take the patient off medicine. So usually I tell the patient, we'll start your medicine. I usually don't start from first visit. I give a 3 month period to reassess the thyroid and see if the thyroid hormone, the thyroid gland fixed itself, especially if the TSH is not high, let's say below 10. But if the thyroid has persistent hypothyroidism, usually we put patient on thyroid hormone until the patient in 1 or 2 years, we can visit this point again and see if we can take you off thyroid hormone as you like. The only way to know if you can come off thyroid hormone is to stop the medicine for 2 to 3 weeks. Before next visit, we'll do the blood test. This is the way I do. However, most patients who have very high elevated TPO titer, they probably will need the medicine, especially women who are planning for pregnancy or they have history infertility. Usually we keep them on thyroid medicine, but the short answer, not every patient needs to be on thyroid hormone permanently. You are mute, Dr. Neha. I cannot hear you. Dr. Neha, I cannot hear you.
Can you hear me now?
I can hear you now.
This is the problem. I am unmute, but I cannot be heard. Anyway, so the next question is from Dr. Sabine. She says, excellent presentation. Is radiofrequency ablation done in Abu Dhabi?
Yeah, we have radioactive iodine therapy in Abu Dhabi. We have treatments. In the past, for private sector, we had the only option was really Gulf Hospital, which closed. But I think we have now, Burjeel have this option in the private sector, and we have this option in MediClinic in Dubai. I personally, if I have a patient with thyroid cancer, I send them to Shakhbout, Mafraq Hospital. Many times this hospital will accept patient, even expat, to help with the radioactive iodine therapy. I think they are more systematic in their approach, and they have more experience because most of patients who require radioactive iodine therapy are done in Mafraq Hospital or Shakhbout. But yeah, there's a MediClinic in Dubai. Burjeel here recently opened a center. I hear so. I send my patient to Mafraq, and if they have access to Cleveland, I send them to Cleveland as well.
He says, thank you for this lecture. Is there a recurrence of thyroid problem even after it has been operated?
I didn't hear the question completely, but I think you said if there's a risk of thyroid cancer recurrence after surgery. Yes, so this is an evolving science as well. So the risk of recurrence is extremely low. This depends on the pathology report after surgery. The surgical pathology report will give us hints whether there's a recurrence of cancer. And usually we give radioactive iodine therapy for them, not all of them. Most patients, however, they don't need radioactive iodine therapy. And the risk of, if you remember one of my slides, the survival rate for thyroid cancer is 98% over 5 years. So most patients, they don't have recurrence, they survive, they are cured. In my practice over the last, I think 10 to 15 years, I never saw a patient die from thyroid cancer except once or twice, and they were advanced cases.
Positive. Another comment from Dr. Aisha. A very comprehensive and insightful lecture. Thanks for making it appropriate and relevant. If a patient, her question is, if a patient has a thyroid nodule and also diffuse enlarged thyroid gland with hyperthyroidism and high thyroglobulin, would they need a biopsy?
See the question again. They have hyperthyroidism.
So they have a thyroid nodule and diffuse enlarged thyroid with hyperthyroidism and high thyroglobulin. Would you recommend a biopsy?
So that's a very good question. So one of the things, the thyroglobulin usually, many cases are elevated in patients with hyperthyroidism. So we don't use thyroglobulin as a marker or a determining factor to proceed with a biopsy. The thyroid nodule will need to follow the guidelines of the thyroid system as listed. So if the patient has TR3 and the size of nodule 2 to 2.5 centimeter, need a biopsy, TR4 1.5 centimeter, and TR5 1 centimeter. The thyroid system did not address the hyperthyroidism. The high thyroglobulin has no value, especially if there is no suspicious lymph node. So that's why I don't order thyroglobulin. It's really confusing. It's not going to help the patient. It will confuse the physician and the patient as well. We rely only on the thyroid system to determine which nodule need a biopsy.
That clarifies your query, Dr. Aisha. If you want to ask anything else, please unmute yourself and ask Dr. Khatib. Meanwhile, there are a lot of comments thanking you for your presentation, Dr. Khatib. And just one comment that I'd like to, no, Dr. Aisha is quite happy with your answer. Thank you so much. So just one comment about the queries that are coming in the chat box about participation certificates. So those of you who are licensed with DOH, you will get an email from us giving you the link, but you could go yourself on the DOH through TAM portal and UAE Pass. And there you will get an option of participate to medical education program. You can go on that, select this session as UEMS, diagnosis and management of thyroid nodule, and apply for the certificate. Once you apply, we get a notification from DOH, and in a couple of days, we'll try to approve that application. Once that approval has gone from us, again, you will get a notification from DOH itself telling you that your certificate is ready and you can download it. So the certificates are now sent through DOH. So please go and apply for it as soon as possible so that we can approve it and send it to you. For those who are not licensed with DOH, you can email to Academic Affairs, and it has just posted that in the chat box. And we will make a certificate, a non-DOH certificate for you. But for all Abu Dhabi licensed doctors, nurses, and technicians, it has to be through DOH. There's a comment about why it has been made so difficult. I am not the right person to answer that. It is from the Department of Health Abu Dhabi, who are now monitoring and managing all the CMEs. So to get a CME accredited for whatever hours that it's worth, it has to go through DOH, and DOH is the one who's going to issue you the certificate. Our role is only to approve your participation, which we will do once you apply. So thank you very much, Dr. Khatib, for this excellent presentation. We did, and we had a lot of participants, almost 100, and I'm sure everybody benefited from that. So thanks a lot.
Thank you.
Anything you'd like to say in the end?
No, thank you all for attendance. I appreciate your coming and listening to me. And again, thank you, Dr. Neha, for nominating me to give that presentation. Thank you. Thank you. I cannot hear you, but I think thank you so much. The voice is gone. Bye-bye. Bye-bye. Thank you.